Top Med Talk.
Hi, it's Monty Mythen here. Welcome back to EBPOM 2020, live from London, actually live from the Top Med Talk studios here in London. So without any further ado, I'm going to dive straight in and introduce our US anchor for Top Med Talk, Desiree Chappell, who's going to be leading on this session.
Well, Monty, I'm glad you're all comfy there in your chair in our Top Med Talk studios. I'm based in Louisville, Kentucky. I wish I were in London, green with jealousy. We're halfway through our second day, which is fantastic. Great success, lots of wonderful feedback on all the social media platforms for EBPOM and Top Med Talk, so that's super exciting. But it really is my pleasure to introduce this very special Medtronic session on the PRODIGY study. And PRODIGY is the prediction of opioid induced respiratory depression monitored by capnoGraphY. And here to tell us a little bit more about the study and take a deeper dive is Ashish Khanna, who's joining us from my neck of the woods in the US. He's in Winston-Salem, North Carolina. He's an intensivist, anesthesiologist, and associate professor there at Wake Forest University School of Medicine. Ashish, thank you so much for taking the time out in this early morning, even though for anesthesiology it's not that early, to join us. And how have you been enjoying the conference so far?
It's been great. I have been so impressed by the fact that I almost feel I'm there. And I think the best part of it is actually seeing Monty in the London studio. So I was looking at him yesterday and there was traffic in the background and I almost felt I was in London. So I was trying to imagine, yes, you're in London. Actually, I was doing my shift as an anesthesiologist in the hospital and, people were like walking by me and they're like, who is this guy? I was like, well, look, I am in a meeting. It's in London. I'm actually in London right now. So you guys are doing a fabulous job of taking us to London. And, again, I think the great part is that you can, go in and out of different sessions, different stages. I think that is all very, very nicely done. And like I was telling you, we're planning to do a similar thing for the Society of Critical Care Medicine 50th year anniversary next year. So this is the new norm. We love it. We'll still make it to London one day and from Kentucky and from North Carolina. But hey, for now, this is the best we can do.
Absolutely. Well, Ashish, you were able to record a very great lecture for us on the PRODIGY study. I'm wondering, right before we dive into that, tell us just a little bit more about yourself and what you do there at Wake Forest.
Sure. Yeah. So associate professor of anesthesiology. I'm also section head for research for our division on critical care medicine. My initial training was at Cleveland Clinic, where I trained in anesthesia and did a fellowship in critical care. There, I got very interested in perioperative outcomes research. I had the honor of working with Daniel Sessler, who was my initial mentor. In fact, Leif Sager, who's part of our panel, was also one of my initial mentors. And, I dived very quickly into the world of perioperative outcomes research as soon as I was a junior faculty and got very interested in trying to understand why patients are doing badly on the general care floor. As an intensivist, it affected me a lot. You probably heard it in my talk. Those middle of the night admissions started bothering me. And I was very interested in the rapid response call side of things. With a lot of big data analytics, we were able to do a lot of, neat projects over there. And then after spending about 3.5 years at Cleveland Clinic, I moved to Wake Forest here, and we're doing a lot more in terms of continuous monitoring and improving detection of patient harm on the general care floor over here.
Great. All right. Well, why don't we go ahead and dive into your lecture, and we'll have a chat with you and our panel here in just a bit. So we'll go ahead and get that video loaded up and going.
Good morning, good evening, and good afternoon, wherever you all are tuned in from. Thank you for this opportunity to Professor Monty Mythen and the entire EBPOM steering committee. It is an absolute honor and a pleasure to be here amongst all of you, even though virtually. Today, I'm going to talk to you all about something that affects each one of us and affects each of our patients on the general care floor. It is opioid-induced respiratory depression. Opioid-induced respiratory depression is an important problem. And as the title of my slide suggests, I'm going to be talking to you specifically about the prediction of opioid-induced respiratory depression for our inpatients on hospital wards and whether a change in monitoring practices is going to help us or not as we approach this problem. Here are some of my disclosures. None of this is a conflict of interest with the academic material on my slides today. So the postoperative period seems to be critical. While our patients do really well under anesthesia, the same might not be the case when they recover after surgery. Intraoperative mortality during anesthesia is so low that the number is hard to quantify. It is down to the decimal points. However, the 30-day period after anesthesia or the postoperative period when patients recover from surgery is still a major contributor to the overall causes of deaths in our patients. This paper in Lancet is a perfect illustration of what I'm talking about. About 7.7% of postoperative deaths are all because of this period, the 30-day period after surgery. And it is only third as common as strokes and ischemic heart disease. So if you look at the overall spread of why folks die, it is still a huge problem. What is happening in the postoperative period? A very reasonable explanation might be postoperative respiratory failure, and certainly the numbers suggest that postoperative respiratory failure might be a major contributor to postoperative mortality, and that I just told you is the third most common cause of overall mortality. There are some numbers here that I'd like to talk to you all about. If you look at Get With the Guidelines data from the American Heart Association, nearly half of all in-hospital cardiorespiratory arrests occur on general care floors. There's other data from the European Union that has showed that most inpatient post-op mortality will occur on general care floors and before patients make it into an intensive care unit. And furthermore, this is data from U.S. hospitals estimating that in 2012, in 320 U.S. hospitals, there was nearly 45,000 acute respiratory compromise events that occurred. And when these events occurred, the consequences of these patients did not make it out of the hospital alive. This number jumped up to 80% if there was a preceding cardiac arrest. And then any preceding hypotension prior to this acute respiratory compromise event also substantially increased mortality. More and more, I am setting the stage and letting you all know that hospital care floors or general care floors are not necessarily the safe havens as we thought they would be. Postoperative mortality seems to be really common, and as the numbers on this slide suggest, postoperative respiratory failure might be a significant contributor to postoperative mortality in general. This is other data from the Agency for Healthcare Research and Quality, or the AHRQ, and patient safety indicators are specifically what we look at with AHRQ data. Postoperative respiratory failure is patient safety indicator number 11, and postoperative respiratory failure is really, really common. It is, in terms of a numerator to denominator, it is more common than postoperative sepsis. And in separate, if you look at separate conditions such as pneumonia, sepsis, or cardiac arrest, postoperative respiratory failure is still overall the most common. So a really important patient safety indicator and several sets of numbers that now tell us that it is common, and it is not just common, it is commonly associated with poor outcomes. Opioids and sedatives is something that all of us administer to our patients on the general care floor. And together, this is a deadly combination. This cocktail is associated with about 3 times as much a risk of a cardiac arrest as compared to an opioid or a sedative by itself, or no use of opioids or sedatives. So common culprits together, opioids and sedatives, indeed a very, very, very potent and deadly cocktail for our patients. Let me look at a closer examination of what we know about postoperative respiratory failure. If we use postoperative hypoxemia as an indicator of postoperative respiratory failure, this is initial work from Daniel Sessler's group at Cleveland Clinic that looked at about 850 surgical patients who were monitored continuously with pulse oximetry while they were recovering on the general care ward. The numbers tell a very interesting and somewhat disturbing story. Now remember, this monitoring was blinded and silenced, and spot check or traditional monitoring, that is every 4 to 6 hours, was going on as per hospital policy. Pulse oximetry was being recorded continuously, but there was no intervention based on the continuous pulse oximetry. The numbers, as I said, somewhat disturbing. About a fifth of all patients had 10 to 12 hypoxic minutes per hour under an oxygen saturation threshold of less than 90%. And there was other thresholds that were established. However, the bottom line was that postoperative hypoxemia was common, persistent, prolonged, profound, and disturbingly unnoticed in almost all of these patients. Well, is postoperative hypoxemia is that common? Does something predict for it? Is there an easily usable tool that we can implement and say in the preoperative period, hey, XYZ of my patients is going to get postoperative hypoxemia? My first question was the stop bank score. I looked at a large data set of continuous pulse oximetry recorded patients and aimed to establish whether an increasing stop bank score was an effective predictor of the amount and duration of postoperative hypoxemia. The rationale here was that stop bank scores are a well-validated tool for obstructive sleep apnea in the preoperative period. They're a well-established screening tool, and that we do know that patients with obstructive sleep apnea characteristically have cyclical oxygen desaturations. Keeping all of that in perspective, when we did our analyses that we later on published in the British Journal of Anesthesia, our results are again surprising. Surprising because there was a lot of postoperative hypoxemia in patients who had higher stop bank scores. However, there was no difference in a stop bank score of, say, 8 versus a stop bank score of 2 to 3, or the increasing absolute number on a stop bank score did not correlate with the amount and duration of postoperative hypoxemia for a threshold of 95 or 90 or 85% oxygen saturation. A similar story with the other commonly established culprit that I just spoke to you about is opioids. The thought here was that patients who received long-acting opioids in patient-controlled analgesia solutions would have more postoperative hypoxemia. As their figures here suggest, there was no difference at all in the behavior of postoperative hypoxemia. So we did know that postoperative hypoxemia was common with the use of opioids, but there was no difference whatsoever if IV fentanyl was used in a PCA regime versus IV Dilaudid. So where we were right now was that hypoxemia seemed to be common, and that easily validated tools like the stop bank score and or the type of opioid used did not necessarily predict for it. But is hypoxemia the only problem? And from what I can tell you and what I'm going to tell you later today, it is not. This is really interesting work that was done now more than 10 years ago. And Frank Overdike's group here showed very elegantly that in patients who were on patient-controlled analgesia solutions, and when they were monitored using oximetry and capnometry, respiratory rate issues seem to be far more common than oxygen desaturation issues. So, for example, a duration of events for 2 minutes right here on the x-axis, there is about 4,000 events of a respiratory rate less than 10. Similar duration of events of 2 minutes here on the x-axis in desaturation. There's about 1,000 events of oxygen saturation less than 90%. So yes, we're not comparing apples to apples, but certainly low respiratory rate events appear to be really common. And specifically, this was a data set where patients used a lot of supplemental oxygen, which again is a very, very common issue for our patients on the general care floor. They do tend to get slapped on with a lot of supplemental oxygen. Certainly, respiratory rate or ventilation appears to be a huge problem and an often under-monitored or not monitored at all issue for our patients. So what do we do? We need a flight data recorder. I don't need to tell you why flight data recorders help modern day aviation, but would you get on a plane without a flight data recorder today, even if the pilot told you that he was going to guarantee you going from point A to point B? I don't have a audience polling system, and I'm sure some of you would, because hey, you would be like, doesn't make a difference to me. I'm still going to get from point A to point B whether my aircraft does or does not have a flight data recorder. The issue is not that. The issue is that what if your aircraft goes down? We would never know what really happened without a flight data recorder. Similarly, our patients are crashing and burning on the general care floor, and most often they don't have a flight data recorder. We don't know what happened to them, and we cannot do things to improve their safety and not allow those catastrophic events to repeat themselves. So unfortunately, we're not being fair to our patients. If this was aviation, it would be totally unethical. But hey, that's where we need to talk about the data. So what does the data suggest? The data suggests that about 60% of patients have at least one abnormal vital sign about 1 to 4 hours before an actual cardiorespiratory arrest. And these abnormal vital signs are interesting because as the number of these abnormal vital signs goes up before an actual event, so does the mortality after the event. So here, patients had 3 abnormal vital signs before a cardiac arrest. Their mortality was close to 95%. And that's where monitoring our patients preceding an event is so important, because if we don't intervene here, then we end up with outcomes like this. And that is, again, the concept of a flight data recorder-based continuous monitoring. There is a retrospective registry data that does show that there is an improved adjusted survival rate in patients who are on monitored wards compared to intensive care units, even though patients in an ICU will be sicker. Or look at an under-monitored ward right here and look at how poor the adjusted survival rate is. This is telling data, even though it is large registry-based analyses. The problem we're dealing with, my friends, is the 4 a.m. phenomenon. I coined this term when I was working in a surgical ICU where I used to see a lot of admissions in the middle of the night for nothing. I called it the 4 a.m. phenomenon. A lot of unprecedented ICU admissions, wasteful ICU admissions in the middle of the night. Why does it happen? It happens because of this right here. At 4 o'clock at night, patients in bed turning blue, obstructing, not appropriately monitored. By the time you check in on that patient 2 hours later, it's already too late. It's time to call a code blue. If there was continuous monitoring and there would be an effective afferent and efferent arm for intervention, things would have been way different. You would have intervened way early and probably not allowed a 4 a.m. phenomenon, needless ICU admission to happen, saved money for your institution, improved morale for your patients and caregivers, and also improved outcomes in general. So what do we do? Is smarter monitoring the real answer? This very important closed claims analysis from Lori Lee's group suggests and speaks the same language that I've just been speaking for the last 15 minutes or so. They saw that almost all of their opioid-induced respiratory depression closed claims were preventable with better monitoring and response systems, and that about a half of all events occurred within 2 hours of the last nursing check. This thing is really critical, and why it's critical is because this is that time in between 2 checks where problems happen. 2 hours after last nursing check, that time where there is no monitoring whatsoever. What do we do? Well, if we move forward with continuous monitoring, we need to know that it should improve survival. A nicely done meta-analysis does show that continuous pulse oximetry is associated with significant improvement in detection of hypoxemia on the general care floor. I'm guessing most of this data is driven from Dan Sessler's work. There's a trend towards less ICU transfers. And also capnography, like I just said, especially in patients with oxygen supplementation, serves as an effective early warning tool. Now, what we really need to work on is some of the rescue team data, which is suggestive, but the mortality data that is largely inconclusive. So smarter monitoring or better monitoring is probably the answer for improving patient outcomes on the general care floor. What do we do before we establish monitoring? We need to answer a lot of questions. Who should we monitor? How should we monitor? What exact parameters should we monitor? How should we tailor our alarms to prevent alarm fatigue? Should we really be converting our general care floors into intensive care units? So a lot is to be done, but at the bottom line is still that we need to study the impact of continuous monitoring on patient-centric outcomes using large interventional clinical trials. And what we really need to do as we do more and more of these trials is to, number one, look at the monitoring device and be sure that things such as agreement, clinical relevance, a trending ability, and overall data quality is absolutely up to par with gold standards or certain pre-specified norms. That is the baseline before we start doing anything else. Then we go on to interventional outcome studies, and PRODIGY that I'm going to talk to you about is certainly a type of outcome study, although not necessarily interventional. And then we need to quickly implement these results into clinical practice. And this third step should be an effective step as well. Otherwise, there will be no difference in outcomes that we'll be able to study for our patients in reality or in the real world in clinical performance. So here is the PRODIGY trial. The PRODIGY trial was a global trial spread across 3 continents and 16 different sites, certainly a Herculean effort. And as the name suggests, prediction of opioid-induced respiratory depression on inpatient wards using continuous capnography and oximetry. This trial aimed to look at nearly 2,000 patients initially and finally 1,335 patients who were all on inpatient hospital wards. All of these patients received parenteral opioids and were continuously monitored using capnography and oximetry that was blinded to the healthcare provider. Monitors were blinded, and alarms were silenced. As in our previous work, hospitals and nursing teams were allowed their normal standards of Q4 to Q6 hours vital signs checks. And all of this monitoring data, continuous SpO2, end-tidal CO2, respiratory rate, heart rate, and the integrated pulmonary index, which is a derived index from all of this, was collected in the background. So numbers-wise, again, 2,000 patients assessed for eligibility, 1,335 in the modified full analysis set, and then 1,282 that completed a 1-month follow-up. The primary aim from the PRODIGY trial was really to understand whether we need to monitor all our patients, and if we don't need to monitor all our patients, which patient population do we really need to focus on? What is the highest risk patient population? So the primary aim, in addition to establishing the incidence of opioid-induced respiratory depression, was to derive a risk prediction tool. We called this tool the PRODIGY Risk Prediction Tool, or the PRODIGY Risk Score. How did we derive the risk prediction tool? First of all, we defined a respiratory depression episode. That episode was defined as a respiratory rate less than 5, an SpO2 less than 85%, an end-tidal CO2 less than 15 or greater than 60. Any of these for greater than 3 minutes. Now, the 3 minutes part is important because we didn't want to include a lot of artifact, so we allowed an extended period of time on each of these drops below or in increments above a certain threshold, so we didn't catch a lot of monitor or sensor misplacement kind of alarms. We also included any apnea episode lasting greater than 30 seconds or any pre-specified respiratory opioid related adverse events. All of this was captured on the monitor. All of this monitoring data was then sent to an independent clinical event committee that adjudicated for the RDE episodes. And this step, I do feel, is a strong point of PRODIGY and certainly a novelty of the PRODIGY trial. All of this data could have just been noise, but the clinical event committee then adjudicated thousands and thousands of monitoring hours of data and established what was true episodes versus what was a lot of artifact, and in the end established what was an opioid-induced respiratory depression versus other respiratory depression. Once they'd done all of this, there was potential predictors of opioid-induced respiratory depression that were put into the model, and a final PRODIGY risk score was determined using all the significant predictors and using a multivariate risk prediction modeling methodology. Here is the headline from PRODIGY. The biggest headline was that nearly half of all our patients, that is about 46% of 181 to be precise, had at least one monitor-detected respiratory depression episode that was largely going missing or undetected based on spot check or clinical monitoring otherwise. This is huge in and of itself. It shows how much we are missing. The important question is, does all of these missing episodes really make a difference? So what is the PRODIGY risk prediction tool, or what is the PRODIGY risk score? It is very simple. It is so very simple that all of us can do it at the bedside. I dare say a patient might be able to self-calculate their PRODIGY risk score at some stage. So very simply, it is age greater than the age of 60. Every decade of age adds a certain risk. Male sex, opioid naivety, presence of sleep disordered breathing, and the presence of chronic heart failure. Each of these is weighted into a risk and certain points that add to the sum total of the PRODIGY score. So in orange here is an example for you all, a 65-year-old female patient who is not opioid naive, does not have sleep disordered breathing, but does have chronic heart failure, is a PRODIGY score of 8 plus 7, that's a total of 15. So she comes into the highest risk category of 15 or more than 15 points and is, for example, at a 6 times higher risk of an opioid-induced respiratory depression episode compared to, say, a female patient less than 60 years of age without chronic heart failure, who would be the lowest risk category right here. So this is something that should be on board with every single patient that you admit to your floor, so you can lay all eyes on that patient who's probably at the highest risk. Increase monitoring, increase surveillance, lay all eyes, get a respiratory therapist involved early, get incentive spirometry there, adjust their opioids, adjust their fluids, adjust everything else so they do not have that event that they're so very likely to have otherwise. And that's where PRODIGY is going to hopefully make a difference. It was a fairly stable calibration plot observed to predicted probability, and the area under the curve here was 0.7620, which is a satisfactory sensitivity to 1 minus specificity in terms of model accuracy. Certainly for something as complicated as opioid-induced respiratory depression, we were very happy with the overall results of the AUC ROC for PRODIGY. Here is some actual waveform data from the PRODIGY trial, and it illustrates what I've been talking about. Here is a patient who is being continuously monitored. In blue is end-tidal CO2. The blue dashed lines are where the monitor first detects a no-breath apneic event or episode. In red here is continuous pulse oximetry, and in green here is continuous heart rate. Nothing has happened over here. So continuous pulse oximetry by itself would not have shown anything. However, 15 minutes later, this patient has a clinical event needing IV naloxone reversal or Narcan to salvage this patient. By this time, pulse oximetry has started going up and down, and heart rate has also started changing. However, this is what we want to avoid. We want to intervene here to make a difference here, and that is the whole theme behind a change in culture on surveillance monitoring. What did PRODIGY also want to achieve? PRODIGY also wanted to look at whether specific parameters like end-tidal CO2, SpO2 respiratory rate, and the integrated pulmonary index, which is a combination of these three and heart rate in a fuzzy logic algorithm going from nothing to 10, 10 being a better status than nothing at all. Is each of them independently or in combination a better predictor of opioid-induced respiratory depression, and how do they compare to each other? We also wanted to look at incidence of adverse events overall, healthcare resource utilization, hospital readmission rates, and overall length of stay for our patients. So some certainly important and significant secondary outcomes. How was alarms on the continuously monitored data? Interestingly, a lot of apnea alarms. Almost all of our patients had apnea alarms. Very few of our patients had end-tidal CO2, specifically high end-tidal CO2 alarms. Intermediate was low respiratory rate and low end-tidal CO2 right here. But in combination, these alarms were really, really low again. So bottom line, apnea and apnea as a driver of low integrated pulmonary index was really, really common. And as a continuation of that, this was so common, and in the blue is sensitivity. So sensitivity of the detection of respiratory depression episodes was also the highest here for things like low IPI and apnea. So a lot of events are very high sensitivity. On the other hand, low SpO2 alarms or hypoxemia alarms were less. So low SpO2 is very specific for detection of respiratory depression episodes, especially when it is combined with low end-tidal CO2, which was also not that common. So interesting data. The bottom line here is, again, hypoxemia is not the only answer. Apnea or ventilatory issues are also really, really important. Best combinations may be a combination of multi-parameter monitoring, which looks at not only pulse oximetry, but also looks at ventilatory issues to sort of achieve a happy middle ground of sensitivity and specificity for detection of RD episodes for our patients. And then, as I'm finishing up here, an important question that everyone asks me is, okay, you put patients on continuous monitoring, you detected a lot of device data that suggested respiratory depression episodes. How does clinical data? So a very few of our patients progressed to real serious adverse events. However, patients who had more than one respiratory depression episode had about a 36% higher risk for adverse events that required eventual hospitalization. They were also at 2.5 times a higher risk for adverse events that required rapid response rescue and things like the naloxone administration that I showed you in an actual patient waveform data. So clearly, RDEs are not benign. They are associated with problems that occur downstream. And I dare say patients who have successive RDEs are probably more likely to have problems like this. And here is another important number. Mean hospital length of stay for patients who had more than one RDE episode was about 3 days longer than patients who did not. Furthermore, that translated into cost data here. So patients who had one or more respiratory depression episode had an increased length of stay. I just told you that. However, that was associated with an exponential increase in costs compared to those who did not, where cost did increase with length of stay, but was certainly not an exponential rise. All of this translated into about $4,500 of average hospital costs for US patients who were experiencing respiratory depression episodes. $4,500 that we would truly like to save in today's healthcare environment. With this, I come to the end of my talk today. I hope you all enjoyed this. I hope this is going to ask a lot of questions of you. But just to summarize, respiratory depression episodes are common. They happen all the time for our patients on the floor. We're missing them based on our spot check-based intermittent monitoring. While all RDEs do not translate into clinical adverse events, patients with RDEs have increased risk of adverse events, longer average length of stays, and an exponential increase in hospital costs. The PRODIGY risk score that has been developed with the PRODIGY trial is easy to implement, and it's really a bedside tool that can be used for prediction and of respiratory depression episodes. In the clinical world, it can be used to triage our patients, to risk stratify them, to put all eyes on our patient, to institute proactive measures and early interventions for our patients. That should include continuous cardiorespiratory monitoring, because if we don't have that flight data recorder, then our patients will continue to crash and burn, and we will never know what happened to them. Thank you again for all of your time today. I look forward to the panel discussion. And once more, this is a really, really important patient care area, and I'm hoping that we're going to have a lot of questions afterwards. Thanks again.
Top Med Talk.
Thanks for downloading Top Med Talk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, Top Med Talk is the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.